in terms of your leadership of teams, making difficult decisions, having tough conversations with families about a sick loved one or with patients about a negative or scary diagnosis. And so what we do believe is that you can relearn, retrain those skills to apply actually quite well in the leadership perspective.
Hey everyone, welcome to Leadership Rounds, a podcast shining a spotlight on exceptional clinician executives thriving and driving innovation at the intersection of business and healthcare. I'm your host, Dr. Reena Pande, and together we'll explore the wisdom and insights of great healthcare executives and craft a prescription for leadership success, one candid conversation at a time.
Let's get started. Laura, it is such a pleasure to have you on the podcast. I am thrilled that you were able to carve out time to chat with me and for our listeners to hear your story. As you know, and as we've chatted about, I think we share this theme of elevating physician leaders and physician executives. And your work at McKinsey has focused on just that. And you've written a couple of amazing articles this past few years talking about this topic. And so I was thrilled to have you on because the focus of this podcast is really shining a light on amazing physician leaders or clinician leaders, I should be broader, clinician leaders of which you are one. And then it just happens that your love is this topic as well. So super excited to get into the topic with you. Welcome. Thank you for joining.
Thank you so much for having me. I'm excited to be here and to talk about this.
Well, before we get into your work and your research and the data and, physician leadership and all this, I'd love to just hear your story and have you tell your story to our listeners. Physician by training, now at McKinsey. How did you get from there to here, and what was your tale? Would love to have you share.
Sure. I'd say I wanted to be a physician from a very young age. And kind of took a direct path straight through college and into medical school. But when I got into medical school, and particularly when I got into my third year of clinical rotations and was really fully immersed in the hospital and clinic setting, I found that I had idealized what it would be to be a physician.
Yeah.
And how things worked. And so getting behind that curtain, I discovered that there were so many systemic barriers to getting patients the right care in a high quality, low cost or cost effective way. And that, a lot of patients and families were confused. A lot of physicians and clinicians more broadly were burnt out and actually not having the best time either. And so the system really wasn't working for patients and it wasn't working for clinicians either. And so I'd say from third year, I sort of embarked on a thought process, a thought journey of how could I make an impact on the system level delivery of care to improve the way that care is delivered by clinicians and experienced by patients, kind of across. I started out kind of across US, but really globally is now my focus. I started the traditional route. If you're a physician or a training physician in an academic setting, if you don't want to be 100% clinical, you should be 80-20 research.
Yeah.
And so I initially had a brief career in health services research. But I found that when I looked at how decisions were being made, no one was looking to even health services research, or very rarely, to say, oh, we should change this policy or we should do something differently as a result of this. But even what was groundbreaking health services research.
Right.
And so then I thought, okay, maybe I should be part of the policy making. Maybe I should set the policy. And so I worked about 18 months with CMS and the Center for Innovation there, and did some work. I went in doing some work at arm's length on ACOs. I was intended to work on the duals ACO, but at that time there was not political will to move that forward, and it ended up being about the time that macro was passed. And so I ended up spending a fair amount of time on a SWAT team to translate the macro law into the first regulations for the quality payment program. Mm-hmm. But through that, I also found that often the way that the decisions were made was there were not a lot of clinicians at the table.
Yeah.
Very purposefully to avoid conflict of interest. Not many stakeholders were in the discussions. those who would actually be affected. And sometimes the evidence base or what was the right thing to do was trumped by the political talking points.
Yeah.
And so that was frustrating. And I thought, okay, well, maybe if I came closer to the delivery of care, maybe if I were in a hospital administration, for example, I'd at least be able to set the direction for my group, my health system, my hospital, my physician group. And so I sort of set my sights maybe on that as being the place I could have an impact. At that point, I thought, I'm not going back to get another degree.
Yeah.
I already had an MD and a master's and residency training. And so I thought, McKinsey would be like an on-the-job MBA.
Yeah.
And so that's why I entered McKinsey, because I thought, okay, they're really going to train me in how to think business and strategy.
Mm-hmm.
But then I got there and I actually found I really enjoy my work.
Mm-hmm.
So I'm really enjoying what I'm doing. I feel like I'm partnering with those healthcare leaders who are ready to make a change or at a moment of change.
I love that.
And so I'm still here.
I love that. I mean, it's so interesting, right? At every turn, there's this maybe dissatisfaction. I don't know if that's too strong a word for you. Yeah. I certainly felt it. So when I was making all my moves, but it's this trying to scratch like one notch further, right? Like, why can't we do X? Why can't we do Y? I hear and how you're describing each of your moves. It's like you get to some point and go, we're limited in doing what we want by something. Let me go see if I can make change in that area. And you just keep knocking on doors, which is so cool.
Yeah,
at
exactly
McKinsey, right. Where did you land up at McKinsey? I mean, it's obviously a large organization. It's so interesting where, the part of McKinsey you have become part of, where you lead. But how even within McKinsey did you get to that specific expertise? And tell us a little bit about exactly what your role is.
Yeah. So I'm now a partner with McKinsey and I lead our physician practice, which is partly how I came to be leading this thinking about physician leadership and physician CEOs specifically. And I also lead our clinical operations work. So a lot of my work is not 100% on the operations side. I still do a fair amount of strategy, but thinking through how do we actually operationalize care for patients. Mm-hmm. It was both things were just a natural fit. In the spirit in which I came to McKinsey thinking I was going to get an on-the-job MBA, I also thought I'd just take a tour of the healthcare ecosystem. Right. I thought, I'll stay 2 or 3 years. I'll try payer work. I'll try policy work, from the McKinsey side. I thought I'd just sort of like try each stakeholder. And then my very first study was with the health system, and it felt most natural. I have done other work with, social sector, with payers, but I find that being on the care delivery side feels most closely aligned with my passion, which is bringing the right care to patients and making life better for the clinicians that are delivering it. Yeah. And so that's kind of how I focused in there.
So what does it mean to lead the physician practice exactly?
Yeah, there I lead our annual physician survey to keep a finger on the pulse on how is the average physician thinking about their work, what's causing them burnout, what's making them stay or leave from a given job, how are they selecting work, how are they thinking about big care transitions, for example, the transition to virtual care or home health. And then on the day-to-day basis, how are we actually deploying physicians? What is the role of the physician within a care team? And how do we keep them satisfied while also delivering the best patient care?
Yeah. Absolutely. When you think of physician, and we'll get into the research in a second, maybe this is a good segue. Obviously, as you and I both know, physicians come in a trillion different shapes and sizes and are in the healthcare ecosystem in a lot of different places. So when you guys think as a practice of who you're looking to survey, like what are the phenotypes or archetypes maybe of the types of physicians that you're most focused on? Care deliverers on the ground? Are we talking provider, administrator? Are we talking payer leaders? Are we talking, startup executives? Like where in the ecosystem are you most focused?
So historically, the annual survey that I mentioned, that's care deliverers. We're looking at across a broad swath of physicians across specialties who spend the majority of their time delivering patient care across a variety of settings, as well as, for-profit, not-for-profit, employed, independent, large group, small group. So we're trying to really just get a cross-section, and we've done some looks as well at what are the differences between some of those cuts or groups.
Mm-hmm.
For example, we've published on how do employed versus independent physicians think about care and experience care delivery. But most recently, leading into this look at the physician leader,
Mm-hmm.
we launched a new survey adjacent, which was actually looking to survey folks who are already physician leaders, those who are spending a majority of their time or even 100% of their time in an administrative leadership role. So
Great.
CEOs themselves was a small proportion, mostly those who were, say, C-suite, one level below the CEO, or one or two levels down if it were a large enough organization.
Very cool. So was this the first time you guys did a physician leadership survey in addition to your
yes.
more general physician survey?
This
Very
is the
cool.
first
I didn't
time we
realize
did
it
a
was the
leader.
first. Okay, so let's dig
Yes.
into it because I think
Yes,
the
this is
data that you guys published last year was so interesting in a couple of articles, and I'm sure I loved reading it, and I'm sure you'll love talking about it.
Yeah.
I mean, a couple of really interesting observations. First of all, like there was a subheading in one of the articles, which we can link in the podcast notes so people can have access to these articles. But from leading care to leading companies, which I just loved that framing. And there was such an interesting stat, right, which was 60% of U.S. physician leaders surveyed expressed interest in becoming CEOs, but only 15% of healthcare CEOs today come from clinical backgrounds. So there's this disconnect, right? And I would just love for you to share a little bit about that work, how it came to be. Now that I'm understanding it was the first time you guys have done a physician leadership survey, would just love to hear about the genesis of it and what that entailed, and then we can dig into some of the details.
Yeah. So I'd say two things. For me personally, from the beginning, when I first joined McKinsey, I was somewhat shocked at the lack of physicians in the leadership level of the companies that I was serving and the organizations that I was serving. Just the physician voice and the clinical voice was often absent or at least minimized in many of the decisions that were being made that were relevant to patient care. And so I sort of started thinking through that, and ultimately that's how we circled back to the need for more investment in physician leaders. Simultaneously, McKinsey has decades-long, book of research on what makes an excellent CEO, agnostic of industry, and agnostic of background. And so the genesis of this, myself and two of my colleagues, Amit Shah and Sanjeev Bakshi, and we came together to say, how can we partner with the broader the broader CEO excellence practice to prioritize physicians as a cohort to invest in to become excellent CEOs? And then
Amazing.
I know we may circle back to this at the end, but the rationale is healthcare is under an intense amount of pressure, financially, socially, culturally in the US right now. And we believe that physicians are the best positioned because of their clinical knowledge to be able to combine that with the other skills needed to be an excellent CEO in order to deliver on mission and margin.
I agree with you wholeheartedly. And I'm glad you went there because it was a question I wanted to ask you anyway, which is there's going to be some naysayers out there who say, right, okay, well, so what if 60% of physician leaders want to be the CEO? Like, who's to say they should be? What's the data to support like having more physicians in leadership, more senior leadership positions, right? And I was thinking, I did a podcast recently with Rebecca Mitchell, who's a physician and now investor, former product leader, and at Scrub Capital, and their whole thesis is, physician and clinician LPs on the one hand as smart investors and investing in clinician-led organizations because they see the potential ROI there. So curious what you guys see from the McKinsey data and client vantage point as to why you feel so strongly about that point.
So there is, as you said, there is research to say that, that there are some examples, right? There's some research that shows that the quality scores are higher or that the U.S. News and World Report's scores, which are kind of holistic quality and beyond, are higher for physician-led health systems versus non. There's also research that has shown there's no difference. So but there's more, qualitatively in our work, we're all physicians ourselves.
Yeah.
And we just believe that this is a group that has a huge amount of potential, not just from an interest level, but from a capability perspective
100%.
that's really underrepresented and underutilized.
Yeah. I mean, I'm preaching to the choir and you're preaching to the choir. I believe this to be true, which is partly why I do this work at Oxeon and, have positioned myself to help other clinician leaders develop and be positioned to have impact in these leadership positions. So I'm with you 100%. I'd love to dig into like some of the things you guys found though in your survey work, right? Which are, some really interesting findings. The first, maybe we can just get into like the theme that stood out for me around this sort of vicious cycle of physician leaders, often being perceived or maybe misperceived by others, and frankly, also by themselves, by ourselves, as not having business acumen or not being able to marry clinical skills with business skills, and there were areas that the physician leaders in your survey actually acknowledged as areas of limitation, but we'll get more to the limitations and the strengths. But like this idea that because people perceive us as not being capable, we're not put in roles where we can get the reps and get the experience, and then you enter this vicious cycle, right? Would love to hear your thoughts on that and how that played out in your data.
Yeah, I think that there's both the vicious cycle of there is a perception gap that was recognized by a subset of the physician leaders we surveyed as a barrier. Mm-hmm. Also, came up. In addition to the survey, we've interviewed now about 50 sitting physician CEOs. And so, as well as other executive recruiters like yourself and, board members, former CEOs. So kind of broad swath of those who are in these seats and are making the decisions for who should be in these seats. And so it is recognized beyond the physicians who feel it as a ceiling for themselves, that there is a perception by many that physicians are not well adept to lead. So I think that, that's one. Number two is also people mentor those who look like themselves. So in the same way other underrepresented groups struggle to find mentorship and sponsorship, I think physicians also struggle to find those who sponsor them, who are not, because they're trying to rise into a seat that may not be held by a physician today. And then the other third factor to call out, beyond the vicious cycle, is just a time lag that is real. So as a physician, you spend a decade training to be, you pursue an additional medical degree, you pursue additional residency training, fellowship even, depending what direction you head. That same decade is being spent by someone who went into healthcare administration straight out of undergrad, developing the set of skills that then we can point to and say physicians lack these skills.
Yeah, for sure. I mean, I was in my mid-30s before I made the move to something business-oriented. Late 30s, right? I can't even do the math anymore. But I mean, I am your poster child of med school, residency, fellowship, super subspecialty fellowship, research time, all of the above. Yes. Faculty member with a 75-25, actually more in my case, 50-50 clinical and clinical research. I was more clinical than the typical academic doc. Yeah. And then I was like, oh, wait, I want to go to something different. Yeah. And I didn't know nothing. I didn't know what ROI meant. I didn't know what EBITDA meant. I didn't know what COGS meant, right? I've said this before. Yeah. And I needed people to take a chance on me and give me the opportunity. But someone could have looked at me and said, why would this person know anything? And why would we? Someone saw the DNA in me and was willing to give me a chance. But to be fair, I mean, my son's a recent college graduate. He's got buddies who just went off to McKinsey and, the investment banking and other roles. And they're already getting those reps of understanding the business world. So it's really interesting point that I haven't spent as much time thinking about.
Similarly, that's partly how I ended up at McKinsey as well, is when I made that decision that I needed to move more to the business side of things, business and management. I had one mentor that was willing to take a chance on me, but wasn't able to provide me a role that was, it was still had significant clinical responsibility and no true way to learn the non-clinical skills that I felt were a gap. And then others kind of laughed and said, what do you, what's, okay, so your only management experience at this point is chief resident? Yeah.
Right.
Yeah.
That said, and you guys talk about this in one of your pieces, there are so many learnings from our clinical training that do actually translate if we just stop and look and listen. I actually wrote a whole essay on this topic a few months ago. I can't remember what the exact title was, but the hidden lessons, that I learned from my clinical training. Like we've run codes, we've managed teams, we've navigated through ambiguity, we've managed risk, we've done all the things, right? So I would love to hear what you guys learned about that topic, because I do think though we get to it later, get to the business world sometimes later, there actually were lessons learned that are applicable if we stop and pay attention and apply them in the right way.
That's right. We've dubbed it the double-edged sword of clinical training, but it is not wasted time. There are lessons and strengths that you learn through that process that others don't have, especially straight out of undergrad. In terms of your leadership of teams, making difficult decisions, having tough conversations with families about a sick loved one or with patients about a negative or scary diagnosis. And so what we do believe is that you can relearn, retrain those skills to apply actually quite well in the leadership perspective. A couple examples I mentioned already, having tough conversations with patients and families. You mentioned leading teams, leading codes. You are the team leader by default. Sometimes that is a challenge. You have to retrain that a little bit to how do I also influence if I'm not the de facto leader. But you have that experience leading teams and leading with authority. You also have, I think the diagnostic process is quite applicable to how you might make a strategic decision.
Yes.
So if you think about, you're calling various quantitative and qualitative information from the patient history, from the diagnostic results, to then come up with a short differential diagnosis, reprioritize it, and come to a prioritized treatment plan. There's shared decision making with the family about how will we view the risks and benefits and trade-offs. And it's the same way when you make a business decision. Sometimes you're making those decisions with imperfect information. And you have
100%.
to pull from a suite of experts, consultants, for example.
I couldn't agree more. Yeah, I love the point about being a diagnostician, because I think of myself that way, and I see it in others. It is how we're trained, right? Like you give me like a mass of data and like a chaotic set of qualitative and quantitative data points. Yeah, my brain will quickly order them and put them into buckets and think about potential solutions for each. And it's like exactly the kind of thinking that you need to apply in the business environment that we're literally trained to do. And I mean, in a very complex environment. So I think you're spot on. There's a nuance to this, which you're getting at, which I think is really interesting, which is it's the same skill, but you have to be able to kind of turn it and apply it a little bit differently in a different environment. So you talk a little bit about risk aversion, and maybe you can dig in there and some of the examples that you've heard from the folks that you've interviewed, because I think that's right. Like I think sometimes I learned to work to limit outliers, right? Like my head goes to like I can't have a death. So I work on this end of the spectrum, but like my peers are working on the bell curve. And like I had to really learn how to kind of reorient my thinking. What did you guys learn in the course of your research? And like what did some of your interviewees say about topics like that, about how to like reorient the learning to a different environment?
Yeah, I think that's exactly spot on, Reena. Not every decision is life and death. And in the business context, we talk about one-way doors and two-way doors. And really, 90% of the decisions you're making are two-way doors. There's something that right now we're going to deprioritize this, but we will be able to come back in the future. Whereas something, firing someone, that's usually a one-way door, as an example. Sometimes in a merger context, you may be in a one-way door where if you don't move now, you're going to have lost the window. But most things that you're doing are really two-way streets. And so just bringing that mindset of relaxing on the sort of the importance of getting the decision 100% right can help physicians kind of retrain and say, okay, how do I kind of take I'll use my bias, an emergency department triage mindset to this decision versus, I'm the subspecialist who's the final source of the answer.
Yeah. Yeah. And like, what context does it have to be an A+ and where can a B+ suffice?
Exactly.
I hate thinking that way because I'm the one who sat in the front of the room in med school and I was a striver. But I have had to like retrain to go like, that's enough. Like, getting it out is acceptable in this case. I don't need to like dot every I and cross every T. But I do think like that's a challenge for us that I'm generalizing that some people need to overcome.
No, you're right.
Yeah.
Well,
go ahead.
Well, if you think about how a physician even came to be in medical school, that perfectionism is what led to the ability to make the grades and the scores that were needed to get into medical school in the first place. And so there's a little bit of that ingrained in us.
Totally. But the flip is that like we do often have to make decisions with limited data and go with what we've got and iterate, right? So
that's right.
Even in like really complex, what might be one-way door, I love that one-way, two-way door analogy. In those environments, I'm sure you were in the ER and there were times where you just had to make a decision with the knowledge you had at the moment. So we are capable of doing that too, which is interesting to think about. Yeah.
I think doing so with humility and just admitting when you're, you think this is the right answer, but we're going to set a checkpoint to revisit. Same way you would set a follow-up appointment with a patient. We're going to start this treatment now. And we're going to check in a week, 2 weeks, a month, whatever the right time frame is for the solution you're recommending.
Yeah.
That works in the management context as well.
I want to go back actually to some of the strengths and weaknesses that you guys unearthed, which I think are so interesting. And this mismatch in perception coming from like clinician leaders themselves and non-clinician leaders who have a different opinion about what we may or may not be good at. So would love for you to dig in on that. Like, what did you see? What were some of the things that physician leaders articulated as their strengths and their weaknesses, and where were the gaps between the perception of them?
I think some of what you'd expect came lowest. Financial acuity and M&A. But physician leaders on average were higher scoring, relatively high scoring, greater than 4 out of 5 confidence in their ability to lead large teams, manage complex people dynamics, operations, as well as strategy.
Interesting.
Yeah.
Do you think that couple questions to dig in, like do you think we're all defining the words the same way? Like when you asked your physician, these are your physician leaders, so they're not your general physician survey. So they are people who should sit in a seat where they know what operations means and what strategy means. So first question is, are we using the same definitions for things?
Impossible to know for sure. I suspect we're closer, as you mentioned, because the cohort is physician leaders.
Yeah.
We may, you have to think we may also be examining a cohort who is more operationally minded than the average physician to start, which is how they came to, seek this leadership role. But
yeah. And what were the perceptions from non-clinician, other CEOs and other leaders that you guys surveyed on physician leadership?
Yeah, and I'll say this is more from qualitative interviews.
Okay.
We haven't comprehensively surveyed non-physician leaders, but it's that specifically some of the physician weak points are around finance. I think there's mutual agreement on that one, but operations and an operational rigor and mindset of actually sort of manage like a monthly operating plan or operating review where you're rigorously managing a KPI over time and driving a result. I think that's viewed as a weakness for physicians.
Yeah, interesting.
And interestingly, given the strength we discussed or the background of having difficult conversations, often physicians are seen as not being able to have difficult like firing conversations or bring difficult news, particularly to peers. So can you tell a peer who's also a physician leader that they're not cutting it? as well as influencing those who are non-physicians.
Yeah, interesting. So we've talked a lot about where the challenges may be arising. Maybe we could spend a few minutes here talking about what you see next and where there might be some solutions, and who bears responsibility for, addressing this gap that you all have unearthed.
Yeah. We see it as both, there are both individual, of those physicians who seek to be CEO opportunities and responsibilities, as well as institutional.
Mm-hmm.
And it links back to that view of what is the perception gap versus the actual skill and capability gap.
Yeah.
As we dug deeper into that data, we actually saw two cohorts emerging. There's a cohort who is sort of more, none of it's my responsibility. It's all a perception gap, and I have no capability gaps. So sort of an overconfident cohort.
Okay.
There's also a cohort that is essentially, I think I have it all, but there are no no one else. There's a mix there of it's all on me. It's all my responsibility.
Mm.
And there are no perception gaps. It's really just, I haven't been good enough. Might be the undertone. Right.
Interesting.
Yeah. And I think both are wrong.
There's the middle who are leaning in hard to the storyline that there are major gaps and they are themselves responsible for finding ways to fill them.
Yeah.
And then the flip, I hear you, is, oh, those are misperceptions. I actually have no gaps. People just don't understand what I'm capable of.
Yes. And then I think the third cohort is more like, I do have gaps, and the reason I haven't gotten there yet is it's not no one has a misperception about me. I actually don't. I have the gap.
Yeah. I hear you. This is like that middle cohort. It's fine. I'm willing to learn, and it's there's opportunity. Interesting. Yeah. And so, how do you? Well, I'm reflecting. There's a couple things going on in my brain as I'm hearing you. So, I have turned my way of talking about clinician leaders a little bit over the years. I used to come at it very much from a we have gaps perspective. And I have shifted to trying to highlight the things we do well that I don't disagree that we have gaps.
Yeah.
But I also want to balance it with but let's remember all the great value that we bring, et cetera, et cetera. So I'm trying to navigate my thinking as we're talking and wanting to make sure that, yes, we highlight the gaps, but we are also mindful of all the value that a clinician leader at the table brings, right?
Yes.
For sure.
That's right. But coming back to what is the individual versus the institutional solutions?
Yeah.
I think from an individual level, there are some real gaps. I think we could all agree that you're not trained, at least coming out the gate from physician training, on finance, strategy, operations as, an organization would think about it. So really thinking about that 10-year gap in training that, your peer leaders have spent learning those skills, thinking about leadership as its own specialty or discipline. This is another specialty that you're actually going to purposefully pursue. You're going to purposely seek mentorship, sponsorship, apprenticeship in those skills. Some have said that they found coursework useful. Others have said not needed. But everyone who has succeeded, the physician CEOs we've interviewed, have said there was some dedicated, purposeful pursuit of learning the skills that were gaps and closing those gaps.
And do you think it was these were people going back and getting an executive MBA, or nowadays so many folks are getting an MBA or some sort of degree alongside their clinical training, be it at the med school level or frankly even during residency. I know here in Boston there are programs that will sponsor folks to do a business degree at Harvard Business School alongside getting their internal medicine residency training, right? So and those programs are coming on 20 years old. So we now have a large cohort of people who have gone to school. Or is it within an institution getting the leadership almost a fellowship of sorts, right? Of training to be able to have an apprenticeship model where you're really learning from your peers. What have you seen, or what do you think are the best paths to get people?
I think it's both. The on the executive MBA or MBA side of things, you're right. Maybe the new and upcoming generation doesn't have as much of that gap coming out of training as historically folks did before there was the concept of the joint MD MBA.
Mm-hmm.
But it's beyond. It's not just the degree. On the you're bringing us to the institutional side. What are the institutional solutions that are required? And there, it's how does an institution systematically identify physician leaders who have high potential to lead beyond the clinical realm and who are interested, and provide them with the right opportunities and training, but more on the job. What are the formal mentorship systems that are being put into place? What are the on-the-job rotations? If you think about how, someone post-MBA might go to and join, an organization, and health systems have this, payers have this. You spend 2 months in every department with the top executive, understanding what happens there. So how can physicians have a similar rotational leadership training to develop the skills that they might be lacking?
Yeah, I love that fellowship apprenticeship idea. I mean, I know there are payers, as you're pointing out, who do it for clinician leaders. I have a buddy who went through a program at Humana just like this, and I don't know if they do it any longer, but I know folks who have loved that ability, the opportunity to really see and experience firsthand, not just have the book knowledge of an MBA, but really the actual hands-on experience, which, as we know from clinical training, is invaluable to be able to.
Yes, I think that's really the bigger gap versus getting the degree.
Yeah, for sure. Couple last questions before we wrap. So, and we hadn't planned to talk about this, but it's in my head. So, how does AI factor into any of this? Like, is any conversation complete without mentioning AI? But as so much, clinical innovation with AI is just exploding now. I'd be curious to get your thoughts on how we think about physician leadership in that context, especially with all these new innovative tools coming to the fore.
Yeah. Well, most directly, I would think about the way in which an institution identifies physicians with strong potential. AI just accelerates that ability to hone in and pick up signals that may otherwise be noise or be missed. So that it's not often when I work with clients, it's the same two physicians who are the go-tos from administration for everything, rather than building a more diverse bench of physician leaders. And so I think AI can really help with that. How do we identify the right folks and make sure we're not overlooking?
Say more. I'm going to press you a little bit. Like what do you? I think I know what you mean, but I don't want to assume. So when you say AI could be used to identify people with high potential, what do you mean by that?
I'm not even referring to the latest AI advancements of, ChatGPT or Perplexity or anything like that. I'm just referring to a more comprehensive and nuanced set of predictive analytics.
Yeah. Can we get clues from behavior patterns or experiences or ways of handling themselves, right? That clue us into someone. Someone saw that in you. Someone saw that in me. But it had to just be like a human who went, I think this person's got something. Are there more systematic ways that are data driven to be broader and picking out great people who are going to be our next leaders? Yeah.
I think that's exactly.
Neat. Yeah.
And then I also think the other way that it's linked is it comes back to this time that we're in and the speed and complexity of the challenges facing the healthcare industry. And AI is one of those. And I think physicians are particularly well suited to understand what are the appropriate guardrails to put into place, what's the right governance structure, as well as where are the opportunities? What is the highest priority opportunity where AI could really help?
Yeah, I love that. We've talked a lot about gaps, and I'm an inherent and eternal optimist. So I want to end with a positive framing here at the end, which is just curious what gives you the most optimism about physician leadership as we go forward here. So critical that we have great physician leaders. What's giving you optimism?
The finding that 60% of physician leaders wanted to wanted to be CEO. We expected a lower percent wanting to be CEO versus the traditional CQO, CMO as an end role. That potential group that is already thinking, bigger, that gives me a ton of optimism. And we just need to harness that potential, provide the right supports to unlock a next generation of healthcare leadership.
I love it. I think that's like such a wonderful finishing note and positive tone. I am hugely appreciative, Laura, for your time and that you were able to carve out a little bit of space to have this conversation. I mean, you and I know how critical it is to have great physician leaders at the table. And especially, as we're just talking about in this era where there's just a rapid acceleration of clinical innovation, we are capable, and I think getting more people positioned to developed and positioned to have that impact is so critical. So just thank you so much for sharing your research and your time, and just grateful to have you on the podcast with us.
Couldn't agree more, Reena. Thank you so much.
Thanks.
Thanks for listening to another episode of Leadership Rounds, where clinician executives share wisdom and insights on what it means to be an exceptional leader in healthcare. If you enjoyed today's discussion, please subscribe, comment, and share with your friends and fellow leaders in healthcare. Join us next time for another dose of leadership wisdom. Until then, I'm Dr. Reena Pande. Thanks for listening.